this is a vice chancellor of a university who comes into my OPD, pressures borderline CCT 530, and there are early visual field defects, and the patient has been for last 10 years on latanoprost. So this is a very common occurrence. You get a VIP in your OPD, borderline pressures, and this looks like a very excavated disc with a large cup disc ratio. And because of the fear of that personality, such patients are often started on therapy, and you can see this, some visual field defects are there. And that is where OCT comes into play, because there is a absolutely normal RNFL profile, and that tells you that there is a false positive visual field and just a borderline intraocular pressure. Such patients, you can stop the therapy, but keep the patients on a lifetime watch. Every year they have to come for follow-up and serial OCT. So that is the first primary use of OCT in the OPD, to rule out glaucoma in patients with a large physiological cup disc ratio who are often labeled as glaucoma, because the amount of training in diagnosis is not adequate, and that is why the OCT comes in very handy for such patients. So we can stop the treatment confidently and ask the patient to review every 6 to 12 months, 6 months for those who have risk factors such as pseudoexfoliation or disc hemorrhages, or have any cardiovascular disease or diabetes. So this is another patient. So this was referred as a juvenile open angle glaucoma suspect, 22-year-old college student with apparently healthy disc and normal visual fields. And the question was whether he should be put on therapy or no. So maybe Gazela, would you like to comment on this? What does the clinical appearance look like?
So here the discs seem normal, sir.
Yeah. So this is, the patient was referred, and it was referred as patient has not been, there is no glaucoma, there is a healthy disc. And patient came to me for second opinion. So this is what happens. So in the OPD, we miss these patients. Visual fields nearly okay. And now you can see what is happening on the OCT. Left eye, there is a very significant dip in the retinal nerve fiber layer. So this is what we miss, the clinical examination, miss these RNFL defects. Now you can see this is the area of left eye, superior RNFL defect, very clear cut area is lost. And this was the appearance of the disc. Now when you go back and read the disc and see the retinal nerve fiber layer, compare the striations of the right eye with the striations of the left eye. Now here you can see this is the RNFL defect. So that is another use of OCT. If the OCT shows you an area where there is RNFL loss, you go back to your fundus photograph and see in detail. You must try to correlate the OCT with the fundus photograph, and now you can see maybe this area, this area, this area, this area is darker. So there is a clear-cut superior RNFL defect visible in this patient, normal fields, and so it is justified to diagnose the patient and start therapy, because there is a well-defined structural defect. And there's one more very nice thing about the OCT. This is the spectralic OCT. You have a pseudo color map. So here, if clinically the RNFL defect is not visible on this green and blue reflectance, now you can see this was the right eye, but here very nicely this RNFL defect is visible. So before you go to the interpretation of the OCT map, always look at the pseudo multicolor image on the spectralis SAN, because this is where you will pick up the RNFL defects. Even in myopic patient, this blue reflectance is very good. So here you can see clear cut, this RNFL defect visible, which was diagnosed on the OCT, missed on clinical examination because the disc appears very healthy. So this is another patient. So would you like to volunteer, our previous resident? So these are difficult cases, so no, don't worry about getting it wrong.
Yes, sir. So when we see in the
See this, the RNFL profile
Yes,
and
sir.
this RNFL, this is normal or abnormal?
so that is normal.
Very good. So this is what happens. So this is looking like a absolutely normal, all the quadrants appear absolutely normal. Please sit down. So this was passed on as a normal OCT, and what I want to highlight a very important thing about the OCT, because rest of these scans are dependent on the age matched population. So you are comparing these with the normative database. There is only one scan where you are not comparing with the database. That is the most important scan, that is the thickness map. Now if you see, compare, there are two yellow streaks of the healthy RNFL, and see the streaks here. There is a blue streak running in between this yellow RNFL. So this is the area you have to watch out for. So this blue streak tells you that there is an area which may be RNFL defect, and this will not be picked up on any of the global scans on the OCT. But if you see the thickness profile, there is a dip here. You can see the right eye, there is a dip in the RNFL, though it is not reaching the abnormal curve for the normative population. So this is the left eye and this is the right eye, and this was the area of the RNFL defect. So this can be taken as what Dr. Asani showed you was red disease. So this can be taken as a green disease, because on a cursory examination, the OCT is appearing green, normal. But actually the patient has a RNFL defect. So this is other way around. OCT may be green, but there is actually glaucoma. And how you have to pick this up? Always see the thickness map. If there is something missing in the thickness map, such a focal area of defect, that points that there is a early damage to glaucoma, which is not coming up on these global parameters. So this was the RNFL defect, very nicely visible. This is a patient of early glaucoma. Now this is a very common referral. So this is a 51-year-old male. He's already on timolol. Baseline IOPs are 21, 22. Fields are within normal limit. So this is the most common referral we get, that you have to give a second opinion whether patient has glaucoma or doesn't have glaucoma. And this is where OCT is very helpful. Now, there is something specific I want to highlight about the OCT, which is normal variation. You get a bifid RNFL. So you can see this is a normal RNFL, what you usually see. But the superior RNFL is broken into two branches. So this is a physiological variation. Sometimes these patients can be labeled as abnormal because there is a dip here because of the physiological bifid nerve fiber layer. But this is absolutely healthy disc and absolutely normal retinal nerve fiber layer. So we could stop the treatment and ask the patient to be on follow-up. Now this is another case. So now the audience is, so just raise your hand. Is it normal? How many you feel it is normal? How many you feel glaucoma? So first let us go for normal. Are these two discs normal or no? So we have, very good. So how many feel that it is glaucomatous? So you can see now why OCT is useful. It's 50-50. Half are raising that it is normal and half are raising that it is normal. So the problem is that when we clinically see the optic disc in the OPD, we miss these findings. So it is always better to take a fundus photograph, and like the radiologist reads the MRI, that is how you should read a fundus photograph. Now see clearly what we have missed. You always look at these four regions of the RNFL, healthy RNFL, healthy RNFL, healthy RNFL. See this area. So this is a RNFL defect which you can easily miss in the OPD examination, and we had also missed, don't worry. And because this is a IAS Secretary Government of India, so he requires more attention, so he will go through a lot of investigations. Fields are also nearly normal. So he was diagnosed that you don't have glaucoma, you just come for a second opinion. And now this is the OCT. So you can see OD is normal, left eye, inferior RNFL defect. So now half of you were right, half of you were wrong based on the OCT. So again, I'm telling you, if you see this OCT, it doesn't end here, you go back and now see. So this is the area which we missed in clinical examination, and that is why if OCT is showing you a defect, go back and see clinically, definitely this is correlating, there's an inferior RNFL defect. So we were clinically diagnosing this patient as a pre-perimetric glaucoma, and we had to start the patient on therapy because there is a well-defined structural damage occurring to the optic nerve. So this is another one of my colleague from AIMS and referred that you have glaucoma. And this happens, you can see there is a asymmetry of the cup. So if you have patients with asymmetric refractive error, you can get asymmetric cup and looks like what we have been taught traditionally, 0.2 or more cup-disc ratio difference glaucoma. And again, due to asymmetric refractive error, absolutely healthy RNFL, so no glaucoma. So again, from the audience, first poll, how many of you feel there is glaucoma? So I can see 2 hands for glaucoma. So that means most of you feel this is normal. So that is, and another thing is this patient has got absolutely normal intraocular pressure. So that was the clinical impression when this patient was referred, that he's got healthy discs. And again, I am telling you what is very important to see on the fundus photograph, read it very carefully. Focus on these 4 regions. There's a white streaks here, white streaks here, white here. If you compare, there appears to be some loss of these white striations. So concentrate on the right eye. So you can see here, clearly there is an inferior RNFL defect, loss of the inferior retinal nerve fiber layer, clinically not visible, and as you can see from the audience poll, you said this is normal. And many of these hypertensive patients are on systemic beta blockers, so the intraocular pressure may be normal. So based on the OCT, there is an inferior RNFL defect, and patient was clearly diagnosed as glaucoma and started on therapy. This is another very interesting case. So typically referred as a case of juvenile open-angle glaucoma, and patient already was on Travertin, because you know when you see this young person with such an excavated optic nerve head cupping, so it comes into mind this is glaucomatous. And that is where OCT is very helpful. So clearly just a large disc with a large cup-disc ratio, which is totally physiological with a healthy RNFL, so you can rule out glaucoma. Now this becomes slightly difficult because this is a fellow ophthalmologist. So now the stakes are very high. So again from the audience, that is appear normal. How many would you raise a hand for normal? So we have 5 hands for normal. So I think many of you are in that nota category. Neither yes, neither no. So this is now very difficult to diagnose. So this looks quite normal. And there was a very subtle RNFL defect between these 2 blood vessels. And you can see this area which is showing you RNFL defect. So no way you could have diagnosed clinically this patient, fields are normal, and he's a fellow ophthalmologist. And there's a clear-cut RNFL defect. And when you see the fundus photograph, this is the area where this RNFL defect is occurring between these 2 blood vessels. So patient had a structural damage, and we could diagnose as glaucoma. And maybe the time is now running out. So this is a 16-year-old patient. This is the optic disc. And this is the OCT. So what do you feel, glaucomatous or no? How many of you feel it is glaucomatous? And how many of you feel it is normal? So this is the disc photograph, and OCT is absolutely outside normal limits. So this patient, 15 years or 16, is the database is 18 years. So what the operator did, he applied the 18-year-old database to this 15-year-old child. So whenever you have children or patients who are outside the normative database of the machine, you cannot rely on the OCT. So this OCT is showing absolutely that patient is abnormal, but patient is absolutely healthy with an absolutely normal visual field. So this is red disease, false positive. So I think I'll stop here. So you can see how to use the OCT in your OPD, You always do the OCT and then go back and study the fundus picture in detail, and then you will arrive at a diagnosis in a lot of patients which you have clinically missing in the OPD. So thank you very much for your kind attention.